Welcome to MedEd's production of the PCCN exam review. My name is Cammy Fancher and I'm your instructor for this review course. This module, this section, is on hematology and immunology. Actually, there's not a whole lot of immunology type questions. There are a few that I'll go over. Mainly it's about hematology, about bleeding. There's some questions about metabolic syndrome. So I'm going to go over the most important parts. Now this is a sort of a small part of the examination, 2 to 3%, so you may only have 2 or 3 questions. It takes me almost a whole hour to go over the information because I don't know what 2 questions they're going to ask you. We're also going to go over blood products, and they may be under hematology, packed blood, packed cells or FFP, but it may also be under GI, it may be under cardiac. Blood can be given to any patient. So we're going to go over a lot of different pieces that fit together under hematology. So it takes quite a while, at least an hour, so get in a comfortable position and get ready to think about platelet function and bleeding. Now, the first thing we're going to talk about is the stress reaction. And we sort of talked about a little bit under the cardiac, and I know we're going to talk a little bit about in a multi-system. So it's a little bit in each section. When you are stressed, the fight or flight response, something very specific happens to your body, and this has happened over our evolutionary process. If you're running away from a mountain lion, you're stressed. But let's make it more to modern day. Say you're driving on the most crazy freeway that you know of. It's 6 lanes across. The speed limit is 55 miles an hour. You're in the middle lane, and if you went 55 miles an hour, you'd get run over. You're going 80 miles an hour, and you're in a smart car. So you're driving down the middle, going 80 miles an hour in a smart car, and you're in between 2 18-wheelers. And they can't see you, you're in a smart car. So they decide to merge into your lane. You have to slam on your brakes because they're going to run over you. You skid across 3 lanes of traffic, and now you're way over on the edge on the side over there. The traffic's going this way, you're going this way. For some miracle, you didn't get hit. But you're facing that way, and the cars are going this way. When you look in the mirror, what do your eyeballs look like? Whoa, you got to see that dinosaur to participate, right? So your eyes are as big as saucers. What's your heart rate? Cha-ching! Your heart rate is you are tachycardic, you're vasoconstricted, and everything vasoconstricts. All your sphincters do, so if you didn't pee your pants, you felt like you were going to pee your pants, maybe a little brown streak here or there, because everything constricted and shunt blood to your brain, your heart, your diaphragm, right? Some other things happen. Your brain sensed that you were nearly killed, and what happened is your pituitary sent out messages to your body, and your adrenal glands just pumped out a bunch of epinephrine and norepinephrine. Heart rate goes up, vasoconstriction. But what do you think your blood sugar is right now? And you're non-diabetic. Your liver squeezes out a bunch of glucose, and your blood sugar is going to be very elevated in a response, because if I have to run away from this dinosaur, I better have enough blood sugar to enable all my cells to rev up to the highest metabolic rate that they can be at. A couple of other things happen. Your stomach, begins to produce under stress, under regular stress of fight or flight, pump out a lot of hydrochloric acid. And you say, you wonder why that's compensatory. Why is that going to help me flee the dinosaur, fight well, or run away? Well, medical anthropologists believe as we were standing up running away from the mammoth, we may have picked berries or something off a bush to give more energy, and they may have been rancid, had mold on them, maybe bugs. And if you had a very acid content, it would neutralize all that. But another very big theory is that early on, man learned how to have dried meat because they could carry it around with them. So they dried the meat. It's very hard. They chewed on it. And the way we break down protein, first is in the mouth with a little bit of saliva, but it's in the stomach with acid. So if you have acid in your stomach, it's going to break down that protein much faster and have it available for your energy source. The last couple of other things is that when you're stressed, remember you're vasoconstricting, your kidney doesn't see a lot of blood flow, so you're not going to make much urine, and besides you just peed your pants, there's nothing else in there. The other thing that happens with that vasoconstriction from renin is that you begin to hold on to salt and water. So your body is holding on to everything, conserving. I'm in conservation mode because I don't know if I'll get something to drink in a while. And the last thing, even though you're holding on to salt and water, your body becomes hypercoagulable. Your body gets ready for injury so that you'll stop bleeding right away. Now, all those things happen in an instant, right? You get that bolus of epinephrine, norepinephrine, that all happens in an instant. But how long does that last? The stress is gone, you're no longer in danger, so everything went up, but within 90 seconds, or maybe even 2 minutes, all of your levels go back down to normal. Now, how do you feel now? Well, you feel like you're running a marathon, you're exhausted, you're sweaty, you're shaky, but it's over. Your blood sugar is normal, heart rate, blood pressure, everything goes back to normal. Right? That is a normal stress response. That's what we're built for. We're built to be able to respond to stress. But take now that you have MRSA pneumonia, you're horribly sick, you're in the unit, you're intubated, and you're on a ventilator for 10 days. And you're very sick, you're septic, blood pressure's up and down, you're really sick. Now, what's happened to your stress levels? If I took your cortisol level while you're in the car, and I took your cortisol level now, they would be elevated. You are stressed. But now it's not just 90 seconds, 2 minutes, now it's 10 days of being stressed. So why do people in the hospital have complications of blood clots in their legs? Why do they have problems with gastric bleeding? Because they're stressed and they make holes in their stomach from the acid in there. Why do they have elevated blood sugar? Why do they have altered temperature? Well, all of these things are secondary to stress that's meant to be for a short time and now is over a long period of time. So what do we see as complications of critical illness? We see gastric ulcers. Every single person that's admitted to the hospital is on a proton pump inhibitor or H2 blocker. Every patient admitted to the hospital is on some type of deep vein thrombosis prophylaxis. Every patient's getting their blood sugar taken and their blood sugar controlled even when they're not diabetic. Now, some of that's coming into controversy, but that is our clinical practice today. And now you can see why we spend so much time at the bedside preventing the complications of stress, because that's what ends up hurting our patients. They have aspiration pneumonia. They have all these stressful events. So that is the stress response, and it's another good way to think about what happens to the patient. When your patient is admitted to the hospital, no matter what their diagnosis, they have stress and immunosuppression. They're stressed and their immune system doesn't work well. Their skin's not working well, their enterocytes and their upper respiratory and in their GI tract, it's not making mucus, way to get infected, gastric pH problems, maybe they're malnourished to begin with. We don't feed our patients properly with enough calories. They get catabolic and they have multiple infections. So really what I'm trying to present here is another theory, a theoretical framework of critical illness. The patient is stressed and immunocompromised. And if you remember that, you'll remember what we're sort of doing with this tight glucose control. It is turning everybody as soon as possible, getting turning modules for their bed because they're going to need it. Now, one of the things that's going to be on your exam is hospital-acquired infections and sort of what we need to look at that. It is estimated that 40% of all of the infections that we see in the hospital-acquired infections, are UTIs, urinary tract infections. So one of our biggest goals in life is to get the Foley out. Now, I'm an acute care nurse practitioner, so if you are in acute care and I have to volume resuscitate you for whatever reason, I need a Foley because I need to know accurately how much urine you're making every hour, because that tells me how your kidneys are doing, and indirectly it tells me how your heart's doing. If I'm resuscitating you well, you should be making urine. If I'm giving you lots of volume and you're not making urine, something's not right. But 40% of all of them are UTIs. So what is our big response to that? Take the Foley out as soon as possible. Anchor the Foley with good Foley care. Now we know that most men over the age of 65 have BPH, benign prostatic hypertrophy. Putting that Foley in and out is not good for them. The more swollen that prostate gets, some people have to go home with a catheter for 2 weeks before urology will bring them back and take the catheter out. I can tell you that people don't like that. So we need to be very careful. The second type of infection that we see, nosocomial infection, is blood infections. It can be from Lyme, sepsis. It can be from translocation of the bowel. There's a lot of different reasons for people to have blood infections. One more thing that's not on the list that's very important is aspiration pneumonia. Our biggest problem in the hospital is someone who is not awake and alert, maybe altered mental status, maybe is having delirium, has had a full stomach, lays down and aspirates. Aspiration pneumonia causes a terrible pneumonitis and then causes problems. We just had a patient. He, as a young man, has horrible hypertension and had a descending aortic aneurysm dissection. Aneurysm, and then it dissected. He had to go to surgery. It had to be an open repair, and he had lots of complications in the hospital while. But he developed a third laryngeal nerve paralysis. Third laryngeal nerve controls the vocal cords. He was very hoarse, talked like this. Hi, doctor, I need to talk to someone about my voice. He could not, and that he felt like he was screaming, and his vocal cords just wouldn't close. He had a swallow study, and they declared he was passed and he could eat. We sent him home, and all the time he was home, 2 whole days, he was aspirating. He came in with fever, chills, nausea, vomiting, high fever, white count, chest x-ray, looked like ARDS, had aspiration, bilateral aspiration pneumonia. And he's very sick, and he's got to be NPO now, he can't eat, we have a Dopphoff in him, lots of problems. Aspiration pneumonia can happen in our elderly population, and they can come in with silent aspiration. Okay? So nursing interventions, we need to be very careful of our patients who can't swallow, who've had a stroke, a mini stroke, a TIA, and we need to be very conscientious about waiting until they have a swallow study to let us know whether or not they can eat. Oh, I'm so sorry. I just knocked the microphone over. That got your attention. Sorry. I sort of talk with my hands. It's a terrible trait. So now we're going to move a little bit from infection, hospital-acquired infections, and immunology right into bleeding. Right? Now, I work with 8 heart surgeons, and I can tell you I probably know a little bit about bleeding. I can tell you that bleeding will eventually stop. You've always heard a surgeon say that. It's just a little bit of humor. Of course, it stops when the patient exsanguinates. They don't bleed anymore, and they stop bleeding when they're dead. So on this exam, they're going to really kind of ask you about coagulopathies associated with medications like Coumadin, Pradaxa, anticoagulants, antiplatelets. They may also ask you about bleeding associated with DIC, disseminated intravascular coagulopathy. So let's just do a little bit review first. If a vessel, a vein or an artery is lacerated or crushed, so that means if it's internally damaged or externally damaged, right, the patient's going to tear their vessel and they're going to have bleeding. Well, the first thing that vessel is going to do when bleeding starts is identifies I'm losing volume, and the first thing that artery or vein will do is vasoconstrict. So it wants to stop the bleeding. The second thing that happens is thromboxane A2 is secreted. You see that thromboxane A2. That comes from the endothelial cell when the endothelial cell is damaged. What that does is that activates your platelet. Your platelet that's running around in your body, perfectly round and smooth, it's slick. And when it gets down to the capillary bed, the very smallest of your vessels, they really slide through single file. And they slide. They don't stick or bump or trash around. They just slide right through. It's a normal platelet. But once thromboxane A2 is secreted and the platelet gets activated, it changes. The shape changes. It gets very irregular. The 2B3A receptor sites poke out like 2 little Velcro feet. So now instead of sliding through the capillary bed, it begins to tumble and do funny things. So first you have activation, and then you have adhesion. Where the vessel is injured, that platelet will stick to that area. It will adhese, right? Activation, adhesion. And then remember those 2B3A receptor sites, they're going to latch on to fibrinogen, which is floating downstream. And now what do you have? You have this platelet with these little 2B3A feet now collecting strings, and it makes a little web, and anything that's coming downstream will get stuck in there, and you have the beginning of a clot. So activation, adhesion, aggregation. That's how we make a clot. That's normal. Well, we give a drug every day, an antiplatelet drug, that inhibits thromboxane A2 from activating the platelet. Your platelets have a normal number, they're a normal size, they're completely normal. And do you remember what that drug is? It's something you give every day, and it's called aspirin. Aspirin inhibits thromboxane A2 from being secreted. If it's secreted, it doesn't get to the platelet, so the platelets are not activated. So you could have a patient who's 65 years old involved in a motor vehicle crash, terrible, terrible crash, that has a platelet count of 170,000. That's normal. But they're bleeding like a sieve because that patient takes aspirin every day. Aspirin every day is going to inhibit thromboxane every day, so he has 170,000 platelets that are totally dysfunctional. They cannot make a clot. So what do we need to give him if he's on aspirin, if he's on Plavix, if he's on Brilinta, if he's on Effient? If they have a bleeding problem secondary to an antiplatelet, we have to give them platelets. But Cammy, his platelet count's 170,000. I know, but not one of those platelets are going to stick together or work. You have to give him somebody else's platelets that can then respond to thromboxane A2. Okay? So that's a platelet response. Now, we're very concerned. We're living in the platelet era. They said the 1990s were the platelet era, but we haven't gotten out of that yet. Every day there's a new drug coming out, and now we have a very large variety of antiplatelets, because what we've learned is that not every single person responds to aspirin. It is a genetic, chromosomal DNA property that you and I become responders to aspirin, and aspirin inhibits our thromboxane A2. If you have a genetic genome that doesn't do that, I can give you aspirin every day, and it will never affect your platelet. You'll still make a clot. All right? So what are other things that affect platelets? Where alcohol affects platelets. It makes them nice and smooth and greasy and never want to stick together and never make a clot. Well, in 2009, which seems like 100 years ago, the American Hospital Association came out with a statistic that really frightened me. It said that 50% of the people in the hospital admitted as patients, it didn't say 50% of the people in hospitals, as patients, 50% of them have an alcohol-related problem. During that admission, they will have an alcohol-related problem. Well, I work in a surgical unit, post-surgical unit, and I can tell you I have never seen so much withdrawal in my entire career. I've been a nurse for 40 years, and I've never seen so many people that say they don't drink, and then their wife comes in and goes, oh yeah, he drinks every day. As a matter of fact, he drinks maybe 4 or 5 beers at lunch, and then at dinner he drinks 2 or 3 Manhattans, and then 2 or 3 beers before he goes to bed. He's drinking daily. Now remember rule number 1. Don't tell anybody you're taking the test. And what's rule number 2? Patients lie and cheat. And I can tell you, I like to have a drink every once in a while. I don't drink daily. I don't even drink every week. There are lots of times I don't have a drink. But I am never going to tell you that I like Manhattans and I like bourbon. I'm never going to tell you that, because if I told you I had a bourbon every night at cocktail hour, I'm very civilized. If I told you that, you would label me as an alcoholic. I'd wake up with a banana bag, folate, multivitamin, Ativan. I don't drink daily, but that's the key. All right, so alcohol, aspirin, Plavix, Effient, Brilinta, all those antiplatelet drugs. So remember, if you have a patient that has an overdose of an antiplatelet, you got to give them platelets. That's the treatment. Glycoprotein 2B3A inhibitor, you can see on your outline there that those are integralin, Riopro, and Aggrastat. Those are the drugs that we primarily use on the way to the cath lab. NSAIDs. NSAIDs are antiplatelets. But now let's do a fun exercise. You will work Monday, Tuesday, and Wednesday, which is a miracle in itself. You work for 3 days in a row, and you have all the same patients for 3 days. That's a small miracle. Patient consistency. On Monday, you admit Mr. Brown. He's some medical patient, and you notice on admission that he has 170,000 platelets. Fine. And Tuesday goes along, Wednesday comes, and you're looking at labs, and you see that Mr. Brown's platelet count has gone from 170, today it's 70,000. That's a huge drop in platelets, and the thing that you think about is a 50% drop in platelet count. I think about what? What do you think about? Well, many of you, the first thing you might think about is HIT, heparin-induced thrombocytopenia. And that's true, you might think about that. Is that in every patient that sees heparin? No. It's a small amount, but we do see it. What's something else that you think about? I think about sepsis. One of the earliest signs of sepsis, before the patient has a fever, a white count, a blood pressure change, a heart rate change, when that endotoxin starts floating around in the body, in the endothelium, in the capillary bed, the spleen gets irritated, gets inflamed, it gets a little angry, and it starts eating platelets. Right? So early sepsis, you might see a drop in platelets. And then the last thing we think about, really, and something that's on the test, it's disseminated intravascular coagulopathy, or DIC. Now, DIC, you know what, I really prefer the old name, what we learned in the 70s, and that was consumptive coagulopathy. I think that's a much better name because that's sort of what's happening. And as a matter of fact, none of my surgeons ever say the patient's in DIC. They just tell me the patient is coagulopathic. We did everything to make them stop bleeding, but they're still bleeding. Right? They're coagulopathic. So DIC is always a secondary diagnosis. It's not a primary, which means something else happens to the patient first. They have a bad pneumonia. They get septic. They have surgery, they get their leg cut off, they get trauma, they get pancreatitis, they get a burn, a fractured hip, and then they develop DIC. So we have to review a little bit of hemodynamics, right? Cammy, I don't use a PA catheter. We're not talking about a PA catheter, we're just talking about blood flow. How blood flows through the great chambers of the heart and then the great vessels, right? This is going to be a capillary bed in my big toe. Over here is my aorta. The blood pressure in my aorta is 120/80, normal. And then as the blood comes out, remember it's coming out arteries, smaller arteries, smaller arterioles. There's an arteriole that's bringing arterial blood to this capillary bed, and it's got a little muscle fiber. It's called a precapillary sphincter. If I could put a probe in there, the pressure inside of that capillary bed is very low. It's only 30 millimeters of mercury. It's not even systolic, diastolic. So if you looked at blood flow in my capillary bed, it's all going to be going in one direction. It's not pulsatile. It's laminar flow. The other thing that's so important about oncotic pressure, I just told you the answer. The most important thing about this number of 30 millimeters of mercury is that's called oncotic pressure. And that's the pressure that holds everything inside the blood vessel. Right? So if you change oncotic pressure, you're going to change capillary bed permeability. Things are going to be moving in and out that shouldn't be moving in and out. Right? So say something happens to me and I get hypotensive. My sympathetic nervous system gets turned on, the renin-angiotensin system gets turned on, so I get tachycardic and vasoconstricted. This is my big toe. Am I going to have a really lot of blood flow in my big toe? No. Everything's going to vasoconstrict to shunt blood out. So now this capillary bed is not happy. It's not getting arterial blood flow. So the metabolic rate, remember Krebs cycle? Of course you do. You took the test, you made an A, and then you moved on. In the Krebs cycle, if your cell has adequate oxygen and glucose, you have adequate aerobic metabolism. And the byproduct of that is pyruvate. Pyruvate doesn't cause any damage. It's reabsorbed by the body and everything's fine. But if these cells, because of vasoconstriction, all these cells around here are not getting oxygen and glucose, they have to change their metabolic function from aerobic to anaerobic metabolism. And now, with that process, the end product, the metabolic rate of anabolic metabolism is lactic acid. You bet. So there's going to be lactate around here. Very important pearl. If lactates are going up, something is very wrong with your patient. Something is not getting blood flow. I don't know what it is, and I don't know what's causing it. It could be sepsis, low cardiac output, some other hematological problem that's causing all their small blood vessels to clot. I don't know what the problem is, but there's a problem. All right? The cell is not getting oxygen. So it goes to anaerobic metabolism, and you get lactic acid. Now, the precapillary and postcapillary sphincter are very shut down, but the precapillary sphincter responds to all this acidosis, and it opens up. It dilates. Blood comes in. The cells are very happy. Arterial blood giving oxygen and glucose, venous blood picking up trash. But the postcapillary sphincter does not respond at all, not at all, to the sympathetic nervous system or to lactic acidosis. It only responds to the sympathetic nervous system. So what you see in some of these patients is an open door blood coming in, and the blood can't go anywhere. So oncotic pressure goes up, the capillary bed expands, makes big holes in the capillary bed, and volume comes out. The serous blood, not the big vessels, just the serous fluid, and we usually call that third spacing, interstitial edema, or they're all swelled up. I live in the South. People say they're all swelled up like a toad, right? So they're all swelled up. Well, what's left inside that capillary bed are red cells, platelets, fibrinogen, so they start to make clot. So the very first process of DIC and coagulopathy is the body is making clot. It's making it all the microvasculature. It uses up all the clotting factors, consumptive coagulopathy, and now the patient bleeds. So this is a syndrome. It's a problem secondary to stress, to inflammation, to critical illness, and now the patient's bleeding. Right? It's never a primary diagnosis, always secondary. What can cause it? Oh my gosh, anything can cause it. Anything can cause any type of hypotension or shock. Most commonly, it can be caused by anaphylaxis and sepsis. Those are the most common ones. Now, remember that on this test, they might give you vital signs and say, what kind of shock is this? Right? So let's talk about anaphylaxis. Mr. Brown over here is going to go to surgery tomorrow, and I'm doing his pre-op, and I say, Mr. Brown, do you have any allergies? And he says, yes, I'm allergic to penicillin. And I go, la, 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 this is 2013. 80% of the people that say they're allergic to penicillin are not. So I write 1 gram of Kefsol on call to the OR. Nobody picks it up. What should I have asked Mr. Brown? Mr. Brown, what happens when you take penicillin? He goes, oh, well, Cammy, last year I had some penicillin. I blew up like a toad, couldn't breathe, couldn't swallow, almost died. Had to give me all kinds of emergency drugs, almost died. That's called anaphylactic shock. Histamine-mediated anaphylactic shock. So, Susie Q over here is working in the holding area, and she hangs a Kefsol. She's got 5 patients. She's running around. All of a sudden, Mr. Brown's alarm is ringing, and it's tachycardic, and she goes over there. He's got a rash. He's scratching. He's very tachycardic. Blood pressure is dropping, and he looks up at her and says, Susie, I don't feel so good. Yes, stridor. Right. That histamine release is causing, number 1, vasodilatation. That's why his blood pressure drops. And movement of fluid into the upper airways, upper airway tissues, and he has laryngeal edema. Now, what should Susie do? Well, the first thing she should do is say, I need some help over here, call anesthesia. And then the second thing she should do is, she just started that Kefsol. She's got to know that that's the problem, so stop the offending agent. So she stops the Kefsol. Right? But he's still, so he's going to be, excuse me, I have a little laryngeal edema today. He's going to have an airway issue, so she's calling anesthesia. But in the meantime, He's tachycardic and hypotensive. What are you going to do for his hypotension? What is your plan for someone in anaphylactic shock? Excuse me. Well, the first thing you're going to do is remove the offending agent, call for help, manage the airway. You got to give some volume, don't you? He's all vasodilated, so volume. Epinephrine is the perfect next drug. And then you can, of course, give Benadryl, an H2 blocker. You can do all of that. But what's going to save his life is a fast-acting a steroid like hydrocortisone or Solumedrol. He needs steroids. Anaphylactic shock was made for steroids. So I have no problem giving him steroids. I'll give him Benadryl, I'll give him Pepsid, I'll give him whatever else you want according to the algorithm for anaphylaxis, but he needs volume, he needs epinephrine, he needs an airway. He needs an airway. So that's anaphylaxis, okay? Tachycardic, and when you vasodilate, what happens to your blood pressure? The whole thing drops, systolic and diastolic. Very good. Hemolytic blood transfusion reaction can cause it, massive blood transfusion, and actually the definition of that is 6 units of blood or blood products in a 24-hour period. Some of my patients, by the time I get them out of the OR, have had 30 units of uncross-matched blood. They're trauma patients who come in and blood products have poured in, they're still bleeding, and they're in trouble. Okay, 6 units. Prolonged cardiopulmonary bypass, sickle cell. Look at all the things that can cause DIC. But remember, it's secondary, not primary. Now, what's the clinical presentation? Well, the patient has abnormal bleeding. We've used up all their coags, they've clotted off everything, and now they're bleeding. So abnormal bleeding, signs of thrombus. This is difficult to see, but it's very true. The reason it's difficult to see is because it's in the microvasculature, little tiny capillary beds, and you're having clots, so you may not see it. But the first sign is petechia on the flank. Petechia on the flank. You might see level in consciousness change, you might see STT wave changes, hypoxia, belly pain. Depending on where the clotting is occurring, it can happen all over. Patient will be short of breath, chest pain, mental status change, low urine output, proteinuria, abdominal pain, and diarrhea. So petechiae, remember, is going to be the first thing that we're going to see. Now this slide is what you have to know for the exam. Right? You have to know this slide because the doctor says, oh my, I think the patient has DIC. Let's send a DIC panel. You have to know the labs. You have to know normals and abnormals. You have to know PT, PTT. When we're looking for DIC, the platelet count has to be low. It has to be less than 100,000. Okay? The PT and PTT are elevated. They're very high because you use up all your coags. Fibrinogen, which is a coag factor, is going to be low. You've used it up. And when you use fibrinogen to make a clot, it breaks down to FDP, fibrin degradation products. So that will be elevated. And now the D-dimer. The D-dimer is elevated in anyone who makes clot. So if early sepsis, the D-dimer will be elevated because you're making clot. If the patient had a AAA yesterday and they're alive and well today, their D-dimer will be elevated because they made clot to stop the bleeding. So the 3 things you have to remember about a D-dimer. A D-dimer will go up with a DVT. A D-dimer will be elevated with DIC. The D-dimer will be elevated with pulmonary embolus. But the D-dimer, when I say the patient has an elevated D-dimer, I can't say that they have DIC. I can't say that they have a DVT or a pulmonary embolus. I can just say they're making clots somewhere. It's very sensitive, but not specific. Right? And antithrombin 3 is low. Antithrombin 3 is another clotting factor. So, the test is very smart. They may ask you what the normal PT is, a normal PTT. They're going to ask you numbers, but they're going to say, your patient is presenting in DIC. What blood product would you immediately think of to give in this patient to correct their DIC? And you say, gosh, if they're bleeding, maybe they need red blood cells. Okay. Most nurses are going to pick FFP, and he needs FFP. It's got coags in it, coag factors. You're right, But the only blood product that has cryoprecipitate, I told you that. The only blood product that has fibrinogen in it and antithrombin 3 is cryoprecipitate. So here's a very good question for you. This is another clinical practice question. The doctor in the middle of the night calls and says, send coags. What do you send? What do you really send? This doctor, a surgeon, medical doctor, whoever says send coags. Most people would say a PT and a PTT. If my doctor tells me, a surgeon tells me to send coags, I send a PT, a PTT, a fibrinogen, a platelet, and probably an H&H because they must be bleeding. Why are we doing all of this? Right? It includes the fibrinogen. If you never do a fibrinogen, you'll never give cryoprecipitate. And that has antithrombin 3 and fibrinogen in it. So another thing to remember for the test is when it says, what is the medical management of bleeding? What is the medical management of DIC? What's the medical management of anaphylactic shock? What's the medical management of anything? It's always the ABCs. Does this patient have a safe airway? Are they bleeding out of their nose or bleeding out of their mouth? They have a safe airway. Are they breathing? Are they circulating? And really, what we learn in trauma is the first thing you got to do for somebody bleeding to death is put your finger in the hole and stop the bleeding. Problem is, most of our patients don't have a hole. They're bleeding from everywhere. They're coagulopathic. So we have to stop the bleeding. We have to do the ABCs, and we have to resuscitate the patient. You must give them volume replacement, and you may have to give them blood products. Now, blood products are not without risk. Your doctors are under the gun. Every unit of blood that doctor gives a patient is documented and on the internet. So if you go look at cardiothoracic surgeon A, and they use, oh my gosh, they use more blood than anybody in the whole hospital. Cardiovascular patient C doesn't use any blood in the hospital. Oh, let's go to the other doctor. He doesn't use any blood. He must be so good the patient never bleeds. Think that's always the case? No, I think he's somebody that doesn't operate on anybody who's sick. He handpicks his patients. He doesn't operate on anybody that has coagulopathy, nobody emergently. He takes care of the cream of the creme patient. The other guy that's got all the blood products is getting all the car accidents, the transection, having a stroke, transection. He's getting all the people with an ejection fraction of 10%. So he gives a lot of blood. So you have to interpret statistics carefully. Now, what are the risks? The risks are, number one, non-infectious, which really means human error. Somebody drew somebody's lab and put the wrong label on it. All right, so it's human error. Not high, but happens. Two is infection, and people are really thinking here about viral infections. You're worried about hepatitis, HIV, CMV, that's what you're worried about. But if you go to the CDC website, in the continental United States, the chances of you receiving a contaminated unit of blood are very low, about 1 in a million. So our blood products are pretty safe. Immunologic, when I give you somebody's blood, it carries leukocytes. So now, almost all hospitals in the United States, when you order packed cells, before you used to have to order CMV negative. Now, all of the blood is CMV negative, right? But what about when you give FFP? When you give FFP, it can't be leukocyte reduced, right? CMV negative and leukocyte reduced. It can't be leukocyte reduced. And 1 unit of FFP, if you give somebody 1 unit of blood, that came from one donor, you're giving them their leukocytes, right? Unless it's leukocyte reduced. If I give you somebody FFP, 1 unit of FFP usually comes from 20 donors. 20 donors. And you can't make it leukocyte reduced. So if I give somebody 2 of FFP or 4 of FFP, 4 of FFP is 80 people have donated that blood. I'm giving this one recipient 80 people's antibodies. Can they have a reaction? Can they have problems? Does it cause things like increased nosocomial infection? Patients already immunosuppressed. Now we give them all these antibodies. They get more immunosuppressed and more at risk for infection. So we need to be careful of that. Aged blood, if I give you blood and it's only 1 day old, those hemoglobins are relatively young. Remember, hemoglobin's up to about 7 to 14 days, up to 6 weeks. A hemoglobin's bright red, it's got a pretty shape, And normal hemoglobin has the ability to change its shape, to deform, and squeeze through the capillary bed. That's the kind of hemoglobin you want. As hemoglobin ages, as it gets to be about 6 weeks old, it is a fossil. It's hard, it's pale, oxygen gets on it, but it never comes off, and it can't deform anymore. It can't even get through the capillary bed. So you don't want old blood, you want fresh, new blood. What are you going to get when your partner goes down to get blood? Whatever blood product is available for you. So some hospitals now are changing from a 6-week blood to a 3-week blood hold. After 3 weeks, they'll discard it. So those are the major complications. Now this is Dr. Hess. He's one of our attendings. We have an old ICU. This patient just came out of the operating room after 18 hours of being in the operating room, and he's cold, he's hypovolemic, he's bleeding, he's got lots of complications. For your body to make really good clotting factors and to clot bleeding, you have to be normothermic. You have to have a normal temperature. This man is cold, so we've got the warming blanket on him to warm his core temperature so he can make clot. Right? So when somebody is bleeding, after you do a lot of resuscitation, you're still going to think about what's the patient's temperature. Okay, so we're warming him up. So if I'm going to give red blood cells, I'm going to give red blood cells in emergency. This patient is bleeding to death. I'm going to hang him up with the rapid transfuser and put him in really fast. But remember, blood comes from the refrigerator, so it has to be warmed as it goes in. So if I'm going to do a rapid blood transfusion, I'm going to use the whole set and it warms it. Most of the patients you have heart failure, and you're going to give them 2 units of blood. So how are you going to give it? Slow over 4 hours. You're going to give Lasix in between. Another pearl of practice, when you give that Lasix, you know, if the unit of blood 1 is finished, you give the Lasix, you hang unit 2. No. Wait until you make sure that the patient responds to the Lasix. Give 20 Lasix, that should open the door and they should pee like a wizard. If they don't, please don't hang that second unit. The patient soon will be very volume overloaded. Right? Okay. Platelets, well, we can get platelets pretty fast. There's no problem with platelet resuscitation. We can give platelets. But remember, platelets come from multiple pooled donors, packed and pooled. We're going to give a lot of antibodies. Now, fresh frozen plasma. FFP, we are starting now to give back all the clotting factors. Factors 5 and factor 8 are now being given to the patient who's getting FFP. It's perfect. It's perfect. But remember, FFP, you know, is from 20 donors, 1 unit, and you're going to, it's really a bad thing to give somebody 8 or 10 units of FFP. If they're going to be a transplant, if they're going to, you know, need blood in the next year for more surgeries, it makes things very complicated for the patient. Now, cryoprecipitate, that is the correct answer when you want to give what blood product do you want to give a patient with DIC. Sorry, I did it again. What blood product would you like to give? You want to give cryoprecipitate. It has factors 8 and factors 13, so you're giving more factors, but what are you really giving? Fibrinogen and antithrombin 3. That is the key. You are now replacing what the patient really is lacking. Right? You can give cryo pretty quick. Now, another couple of pearls for practice on what you might see on the test. If your patient is end-stage renal failure and we're giving them blood, usually we give them blood when they're having dialysis, right? This guy's not doing so good. He has dialysis on Monday, Wednesday, Friday. It's Sunday night. He's not doing good. We're giving him blood. We'll probably have to give him really early dialysis on Monday or even on Sunday night. Now, when you're giving a bunch of red stuff to somebody, the electrolyte you're most worried about is potassium. Because remember, as those cells get older, and remember you might have blood that's 6 weeks old, those old fossils crack open, and what falls out? Potassium, so they get hyperkalemic. Signs of hyperkalemia: tented T waves, widened QRS, bradycardia. The other thing to remember is that you cannot make clot if your calcium is low. You have to have calcium. If you're given a bunch of yellow stuff, FFP, platelets, FFP, more FFP, it leaches the calcium, and their ionized calcium goes down, and you have to replace it. And then all the other complications, they can get viral infections. TRALI is transfusion-reacted acute lung injury that looks like ARDS. The mortality rate of DIC is very high, very high. It's up to 40 to 60%, it really causes multi-system organ failure. Now, so DIC, you know how to look at it. You know how to look at the labs. And the key in DIC is that platelet count has to be low. It has to be less than 100,000. PT-PTT has to be elevated. Now, anemias, probably the number one reason that our patient has anemia is because we suck all their blood out. We draw blood 4 times a day. In the unit they've been sucked out and you're sucking them out, the patient has nothing left. Don't they look like they've been beaten with a baseball bat? The most common causes are excessive blood loss, the patient's bleeding or we bloodlet them. Destruction of the blood vessel, like an artificial valve, a mechanical valve that's constantly hammering on those hemoglobins and crushing them, killing them. And then ineffective bone marrow to make good blood cells. Okay? So here, very simply, these are the major types of anemias. Microcytic is a small, pathetic-looking hemoglobin. It's pale. It latches onto oxygen. It doesn't carry it very well. Iron deficiency and thalassemia. The most common type of anemia that we see is macrocytic. It's a big, fat hemoglobin, odd shape, doesn't diffuse very well, mainly caused by some cancers, but can be caused by vitamin B12 and folate deficiency. Now, I'm here to tell you that most Americans over the age of 65 are folate and B12 deficient. So this is the most common. Hypothyroidism, alcohol abuse, and drugs. Right? So macrocytic's the most common. Normocytic means 2 things happening. Right? They might be microcytic and bleeding to death. Right? Normocytic means they're just bleeding. Dimorphic means that 2 things are happening. And Heinz body anemia, it's not very common, but the hemoglobin has little black dots on it. It's usually secondary to starvation or dietary depletion. And we actually starve our patients in the ICU. If they've been in the ICU for 2 months, they're probably nutritionally depleted. Right? So we can see that. Now, what are the complications? Now, if I told you that a patient, had decreased exercise tolerance, you said, what, they can't run a marathon anymore, they're anemic? Now, let's talk about an 82-year-old lady who falls and breaks her hip. She's in rehab, and every time she stands up, she gets dizzy and weak because she's hypovolemic because her blood count is so low and she passes out. She can't do rehab. She can't get up and walk to the bathroom. Another thing to remember, please remember this. You and I, haven't you ever gotten down on all fours to look under the bed at a chest tube or some drainage or something, and you got up pretty quick and you got all dizzy and went, whoa, what's that? You were hypovolemic. You were dehydrated and very hypovolemic. And the reason you didn't faint is because cardiac output equals stroke volume times heart rate. Your stroke volume was low, your heart rate went up. Little old people on low pressure, 50 milligrams BID, not going to have a heart rate elevation. So they're going to take a header, right? Hypoxia, of course, cold intolerance, and extreme fatigue. So the treatment really depends on the patient, doesn't it? If the patient's iron deficient, we can give them ferrous sulfate, 300 milligrams TID. And you know what? You and I may not see that result, but in 4 weeks, when that bone marrow starts to wake up and make hemoglobin, it'll make very good hemoglobin. Vitamin supplementation, folate and B12, and epigen. Epigen, erythropoietin, was essentially made for people in renal failure who the kidney, makes erythropoietin, and it doesn't get made, so we give them erythropoietin to stimulate red blood cell production. But when people are immunosuppressed, their bone marrow is suppressed, and we can give them a bunch of epigen, and it doesn't work. So what we end up having to do a lot of times is transfuse the patient. Remember, nobody likes to transfuse, right? So that's a thing to remember about hematology. The last little piece is that you might start seeing some questions here about your cancer patients. Not really chemotherapy, because that's a different test altogether, but just some things to remember about a patient who is receiving chemotherapy, about to receive chemotherapy, or just finished their treatment with chemotherapy and or radiation. The immunosuppression is due to both the cancer cells themselves, the cancer, and the treatment of cancer. So we have nutritional concerns. Many times if they've had radiation, especially to their head and neck, their brain stem is involved and they will not eat. They have food aversion actually, they can't taste anything, everything tastes bad, and they really need to eat for the nutrition so that they can stay alive. Organ dysfunction, right? They'll have multiple organ dysfunction. So number one, they're immunosuppressed, they don't have great blood flow, altered labs, and the second thing is they get very hypercoagulable. This patient, the patient with cancer in the hospital, is the highest risk of dying from a pulmonary embolus. So we need to do everything we can to prevent DVTs. Cancer cells cause it, stress hormones, and the fact that they're on bed rest. So what do you want to remember? You want to remember that you don't want your patient to be a big fat toad. You don't want them to third space. You want to keep the volume in the space that it belongs. You want good oncotic pressures. To have good oncotic pressure, you have to have protein in the body. So what do you have to remember? Good answer to that is everything. Because I don't know what question they're going to ask you. I don't know if they're going to ask you what the normal PT is. What's the normal PTT when you're on heparin? What's the PTT you want when you're on heparin? Right? So you need to remember in DIC, you have a high PT-PTT, high fibrinogen, low platelets, high degradation products, and high D-dimer. In the old days, we gave heparin to people. You might see this. Heparin was given because it actually accelerates the development or the production of antithrombin 3, and it inactivates thrombin and prevents the proliferation of more clots. So some questions. A primary chemical mediator in anaphylactic reaction is? Well, there is such a thing called myocardial depressant factor. There is. But it's not what's seen. It's seen in severe shock, but not what's seen in the development of DIC. Histamine is correct. Complement system, yes, your complement system is turned on when you have anaphylaxis, when you have stress, but it happens after histamine. Histamine is the primary mediator in anaphylaxis. Very good. Which of the following lab diagnostic findings will most likely be seen in DIC? PT and PTT prolonged? Sure, that's true. Fibrinogen increased? No, fibrinogen is decreased. Remember, you're using it all up. Platelet count increased? No, the patient has to have a platelet count less than 100,000, or it's not DIC. D-dimer normal? No, it should be elevated. So the correct answer is A. PT and PTT prolonged. You're widening out. You have no coag pictures. You have trouble making clot. Right? The clinical presentation of DIC. Signs of thrombus formation, that is true. You have to remember that. It's just very difficult to see. Mainly they're the petechiae, little red dots on the flank. Okay? Excessive bleeding, yes. Decrease in platelet function, yes. All of the above. Okay? Now, in summary, we've covered in this 45-minute period a whole lot of information. We talked about the stress reaction. We talked about immunosuppression and Foley's, blood, or hospital-acquired infections. And it is our responsibility, the bedside nurse is the number one person that's going to prevent a hospital-acquired infection. We talked about DIC, bleeding, and the complement system and the problems of bleeding. We talked about anemia. We talked about cancer. What do you need to remember? Everything. Everything. Well, thank you. You need to study. Do practice questions if you can. Remember, on the ACN website, the blueprint is there. And if you have questions, you can call us at MedEd, you can email us at MedEd, and remember, you can also call ACN to ask questions. Thank you very much.